This one is not working. Oh, good. Assalamu alaikum. Thanks very much, Dr. Ahmed, for the kind introduction. First, I'd like to thank the organizers, headed by Dr. Ahmed, for their kind invitation, and I'm really delighted to be with you. Over the next 20 minutes or so, I'm going to talk about the treatment of chronic spontaneous urticaria in special populations, what the recent guidelines say. So the international urticaria guidelines have actually undergone numerous revisions and updates since the development of the first guideline in the year 2000. And these guidelines are published every 4 years. And the most recent one was published in 2021, September 2021. Now, the latest update actually was the result of a consensus which was done in Berlin during the 6th International Consensus Meeting about urticaria, and was updated as a joint venture or a joint initiative between 4 important bodies, including the IACI, the GALEN, EDF, and ABACHI. These are main bodies that actually have an interest in urticaria and produce guidelines on urticaria all the time. Now, I was privileged to be part of the latest 2021 guidelines, which actually has 4 domains: the definition, diagnosis, and management. Further research was also part of the latest guidelines, but for today's sake, I'm going to talk only about the management issues related to urticaria. Now, the management decisions and treatment adjustment based on the new guidelines has actually 3 parameters. So we have these 3 parameters include assessing patients, acting, and then adjusting. So the first part, which is assess, we need to assess the patients and make sure that they're properly diagnosed and they don't have any other conditions, and assess the severity, of course, using different parameters, including the urticaria control test. We need to listen to patients and their treatment preference, and address side effects of treatment. And so this is the initial phase. So the initial phase, you assess your patients, and then you act. Acting means you modify the treatment that the patients are available, look at other options, non-pharmaceutical, for example, like stress element, like the contributing factors that actually contribute to patients' worsening of urticaria, and then, of course, patients' education. Once you've assessed, you've acted, now you adjust. You adjust therapy, stop if the patient had no issues with their condition, step up if the response to therapy is inadequate, and change if patients develop side effects. One of the important assessment scores for chronic urticaria that we currently use in our clinical practice in Cleveland Clinic is the urticaria control test. This is a very simple questionnaire. It's like the asthma control test is based on a set of questions, and it tells you roughly about how patient's condition is behaving over the past 4 weeks or so. So if you have a score of less than 12, then means that the patient is uncontrolled skin condition. So you need to step up your treatment. You need to adjust. You may need to add omalizumab. If the score is between 12 to 15, then this is well controlled, and you continue and try to optimize therapy. Now, the highest score is 16. So the 16 means the patient has completely controlled skin condition, and you may consider stepping down. So, as I said, the urticaria control test is really very simple, very informative. It gives you, good information about how the urticaria is behaving. And if you need the form, for example, the urticaria control test form, we have it in Cleveland Clinic, both in English and Arabic. And this is part of our standard practice now in Cleveland Clinic for patients with chronic urticaria. So the guidelines, I'm not going to go about the guidelines as a whole because it's a long document and I refer to it for the details, but I'm going to talk about the most relevant points here. So according to the guidelines, we should aim as urticariologists, and you can quote me on this term, this is my term, urticariologist. So these are people who are interested and treat urticaria. So we should aim for complete symptom control on all patients. And this, we've achieved about more than 90% consensus on this. So when you see a patient with chronic urticaria, you should aim for complete remission, basically. And we also need to tell patients to stop any medications or any factors that actually can contribute to their disease, like, for example, being on aspirin, being on non-steroidal anti-inflammatory medications, and these are known to actually aggravate urticaria in up to 15 to 20% of the sufferers. Again, now, the interesting part here is that antihistamines remain the mainstay therapy, and they should be considered in all types of urticaria. So whether chronic spontaneous urticaria, CINDU, or chronic inducible urticaria, first-line therapy remains the antihistamines. And we recommended that you can go up to 4 folds of antihistamines. So don't be afraid of using antihistamines. All are safe medications. So we should be aiming for up to 4 fold increase, and this is called, or this is considered as a second-line therapy. So if the patient is not really controlled on the standard therapy, so you can go up to 4-fold, and this is considered as stepping up the treatment here, and this is very important. Now, we also recommended that antihistamines shouldn't be taken as needed for optimum control. I think the antihistamines to be very effective, they need to be taken regularly, even if the patients have no skin lesions. Of course, you, as I said, you adjust therapy and you review patients as you go along. So, I mean, this is my practice. So I put patients on antihistamines for at least 3 months and reassess. And our patients a lot of the time say, "Doctor, can I stop when I have no symptoms?" And this is not really the best practice. I think they should continue for that protracted period of time. 3 months, as I said, is not really, this is basically the practice that we have. And there's no evidence that 3 months or 2 months or 1 month is enough. But I think 3 months will give you a good time to really assess patients with the skin problem. Now, the other important thing is that we actually strongly opposed to using 2 different antihistamines at the same time. In the past, doctors and people interested in urticaria have combined antihistamines, but the current guidelines advise against that. Although this is we had about more than 70% agreement on this, still other experts really were opposing to this. So we have about 20% of the experts saying that, maybe, combining antihistamines could be beneficial on some patients. And again, I'm sure you have a different opinion maybe. Like me, you probably have seen patients benefiting from a combination of antihistamines, not only a single one, or increasing the dose of a single antihistamine. So I think, but as I said, if you are going to follow the guidelines, then we really advise against combining antihistamines. Now, again, we really recommend against using more than 4-fold standard dose of antihistamines. So, and again, I'm sure you have patients like me who had 6 to 8 tablets of Zyrtec, for example, or 6 tablets of fexofenadine. And, you know, they said, doctor, I can't control my symptoms except by using higher antihistamines. Now, the danger of that is that you can get rebound urticaria. So if you have high antihistamines, if you give patients higher than antihistamines than the recommended, than the, higher than 4-fold, then that means you can get rebound urticaria. So the urticaria can get worse with high dose antihistamines. So just again, be careful with that. And I'm sure if you're an urticariologist, you probably have seen this diagram before. This is again a summary of what I've just said. So basically you start with your standard dose of second generation antihistamines, and if needed, you can go up to 4-fold. And if no adequate response in 2 to 4 weeks time, you can add or earlier. So it doesn't have to be 2 to 4 weeks patient suffering. You can add omalizumab even earlier if the patient is not responding or adequately controlled. Now, in my case, because we're a tertiary center, we're the Center of Excellence for Urticaria and angioedema, we see all of these patients come to us actually ready for omalizumab. So we don't really waste a lot of time because patients come to us suffering, et cetera. So we just start omalizumab after doing our assessment, if you like, of the patients. Now, if inadequate response or if the patient is not responding to adding omalizumab, you can give omalizumab for up to 6 months, but you can change if the patient is symptomatic or if there's no adequate treatment. Then you can add cyclosporin, and cyclosporin is very important. You can stop omalizumab and add cyclosporin. Sometimes I don't really stop omalizumab. I give cyclosporin in addition. And again, there is not right or wrong here, but if we're going to follow the guidelines, we should stop the omalizumab and give cyclosporin. Now, if we decide to, the reason we decided to go for omalizumab, because omalizumab is really, FDA approved for chronic spontaneous urticaria, while cyclosporin isn't. And it's used in chronic urticaria as off-label, believe it or not. And the safety profile of omalizumab is far better than cyclosporin. Doesn't really require any monitoring investigations or anything like that. So again, you can use both in combination, or you can stop omalizumab and go directly to cyclosporin. Now, the important things that you haven't seen previously in the urticaria guidelines is that you can go up to 600 milligrams of omalizumab every 2 weeks. So don't be afraid of using omalizumab. It's a very safe medication. We have a large number of patients on it, and we have no issues at all. Now, the other thing in the new guidelines is that of course, we don't really advocate the use of long-term OCS or oral corticosteroids. But if the guidelines say that, consider a short course of systemic steroids in a patient who are experiencing an acute exacerbation. So yes, it's okay to use a short course of steroids, but please avoid using long-term. And unfortunately, through the years I've been practicing here and abroad, the magic pill is OCS, and really this is not the solution for these patients. So people who are sort of afraid of using omalizumab, if you compare the side effects and the risk of omalizumab to oral steroids, you cannot compare. Omalizumab is far safer than oral steroids. And there is now evidence that the cumulative effect of OCS really can be detrimental in certain patients. Now, what about other therapies? We couldn't really make any recommendation for adding, for example, H2 antagonists. This is again a common or used to be a common practice in many centers. So you can add ranitidine, for example, as a H2 antihistamine. But again, my experience is variable. I have patients who, when we added H2 antihistamines to the H1 antagonists, they've done well. Others haven't, experienced a better control of their symptoms. And the guidelines here haven't really made a decision about this. We couldn't agree, really. So we came up with this statement that we cannot make any recommendations about this particular issue. And again, could other treatment options be recommended for treatment of urticaria? Yes. Again, we couldn't make really any recommendation against what to use other than omalizumab or cyclosporin, and antihistamines, of course. So we couldn't really use. There is a long list of medications that was suggested, but there is no evidence. We can use montelukast. There are patients who will respond better on doxepin. Patients respond on hydroxychloroquine, you name it. But again, we couldn't really reach a recommendation and to what therapy or alternative therapy we should use. In my experience, I've used hydroxychloroquine in difficult to treat urticaria patients where there is an element of autoimmunity there, and it worked very well. But as a group of experts of about 60 experts from around the globe, we couldn't reach a recommendation about any of these medications, and everyone has his or her treatment, experience or experience with different therapies. Now, what about children? Children, according to the guidelines, which again was the IACI sort of produced a document in early 2022, saying basically the same. In children, the same treatment algorithm as for adults should be used for children, taking into account the weight-adjusted dosage, et cetera, et cetera. So again, even omalizumab can be used in children with no issues there. And again, pregnancy and lactation, and again, there's no problems really using the same treatment algorithm that I've mentioned earlier, and in pregnancy and lactation. And actually, with regard to Xolair, now there's strong evidence that is safe to use in pregnancy. But again, you have to discuss this with your patients and come up with a better solution during their pregnancy. Some patients, I had patients who said, I can sign anything for you, but keep me on omalizumab during my pregnancy. Others say, look, I'm a bit cautious. I would like to stop and see. So I think it's a decision that you need to make between you and your patients. But overall, there is evidence, strong evidence to suggest that omalizumab can be used in pregnancy and lactation. So finally, I'm going to leave you with these remarks. So again, urticaria is a very common condition. I don't call it a disease. It's a condition with high unmet needs. And I think as an urticariologist, we need to address the gaps among guidelines, because the guidelines are guidelines. They don't really, address all the concerns of the physicians, and of patients. We need to look at real life clinical practice, and we need to listen to our patients and address their expectations and perceptions. With that, I leave you, and I'm happy to take any questions.